Hello, everyone, and thank you for joining us today for our virtual Healthy Minds, Healthy Bodies seminar. As a reminder, all lines will be muted, and the presentation will also be recorded and provided via a follow-up email. So I would like to introduce you to today's presenter is stroke coordinator Jody Andrews, and I'll hand it over to Jody. Thank you, everyone, for joining us today.
Awesome. Thank you so much, Leslie. I would also really quick like to just introduce, I have with me today Beth Johansson and Sarah Vincent. They are also nurses and stroke coordinators at Good Samaritan Regional Medical Center. And so they are my counterparts. So they're going to kind of help with the chat and help a lot with some Q&A. So very thankful that they are here today with me. So we're going to jump right on in. Our presentation today is called Save Time, Save Brain. And we are going to be talking about stroke care, not only stroke care, how we prevent strokes, what we do if somebody is having a stroke, and kind of what Samaritan's role is in that. So it's going to be a wide range of some topics. So to jump right in, Samaritan Health Stroke Services, if you're unfamiliar at Samaritan, we have 5 hospitals within our network. Good Sam, which is in Corvallis, Albany General, which is in Albany, and then we have Samaritan Lebanon Community Hospital, Pacific Communities, and North Lincoln. So the way we kind of break these down for stroke care is by different levels of certification. So Albany and Good Sam are both actually accredited separately for stroke care. So we are primary stroke centers, and then the other 3 hospitals are critical access hospitals is what we call them. So it doesn't mean that you can't get stroke care there. It just means that we trained our staff at Corvallis and Albany more specialized to strokes. So if somebody went to one of the other 3 hospitals, they could receive treatment and then get transferred to Corvallis and Albany, where we do a little bit more education with our doctors and our nurses on continuing that stroke care. So why do we care about strokes? In the United States, every 40 seconds, somebody has a stroke, and every 4 minutes, somebody will die from a stroke. So it's a huge number of people that either have experienced a stroke themselves or directly know somebody who has experienced a stroke. It is the leading cause of long-term disability, and it is the 5th leading cause of death. This has been a change really in the last, 10, 15 years. We've moved from the 3rd leading cause of death down to the 5th, which is thanks to a lot of advancement in stroke care, a lot of education to patients on mitigating their risk factors and getting timely intervention, but it is still that leading cause of long-term disability. Our stroke services in Samaritan, our main goal is reducing that disability for each patient that comes through our doors. So that's why we really focus in on stroke care and stroke awareness. So what is a stroke? Before we dive into all the ways to prevent them, simply put, it is a brain attack. The same mechanism that would cause a heart attack, it's just in the brain instead of in the heart. It's a sudden death of brain cells that can be caused either by a blockage, so a blood clot, a buildup of plaque, etc., or a bleed. So blood is fantastic and we need it to live, but when it spills out of those blood vessels and touches brain tissue, it is extremely dangerous. So like I just mentioned, there are 2 types of strokes. That first one is that blood clot or a blockage, a physical blockage in a blood vessel, and that is called an ischemic stroke. This accounts for about 85 to 87% of all strokes. It is widely the most common, and it is in theory, easier to treat stroke, whereas hemorrhagic strokes, that's a bleed in the brain. This is definitely the most fatal. It is only about 15% of all strokes are hemorrhagic, but of those, it has about an 85% mortality rate. Part of this is, we can do a little bit more for an ischemic stroke where if somebody comes in on time, we can give them a clot busting medication, or if it's a very large clot, we can physically remove that. And I'll talk a little bit about those treatment options in a moment. With a hemorrhagic stroke, you're a little bit more limited to what you can do, whether that's trying to surgically evacuate the bleed, release pressure on the brain, but we're a little bit more limited there, and battling the clock of as blood is touching that brain tissue, it can be really detrimental. So it is definitely a more fatal version. And then you may have heard of TIAs, transient ischemic attacks. We hear people say all the time, my doctor tells me I have had a mini stroke. And that is really the nickname of a TIA. However, it is not a stroke. We view it as a warning sign of a stroke to come. It has those typical like textbook stroke symptoms, but they self-resolve. They're shorter lasting. And the biggest thing is there'd be no evidence of it on any sort of brain imaging. It's like it never happened. So it's really not causing permanent tissue damage in the brain, but whatever is causing those little TIAs, those mini strokes, could cause a true big full-blown stroke. So we definitely encourage people, even if you've had a mini stroke, still get evaluated for that, or don't wait for symptoms to self-resolve thinking maybe they will. We still view it as an emergency. So what are your risk factors for a stroke? Some of these are pretty common and pretty well known. High blood pressure is the #1 risk factor for both types of stroke, both a blood clot or a bleed. Diabetes, atrial fibrillation, obesity, high BMI, high cholesterol, smoking, and this does include vaping, sedentary lifestyle, so lack of exercise, a family or personal stroke history, and illicit drug use. Another one that's developing, there's still some data popping up about this, is the use of oral contraceptives or the birth control pill. There's been some relation that we have seen for younger women who have had a stroke related to that. So that's still a little bit new information. As you can see on this list, there's things that we can prevent and there's things that we can't. So if you have a family history or a personal history of stroke, unfortunately, can't change history. So that one, we just try to find out what else could be changed. High blood pressure, diabetes, high cholesterol, a lot of these things are diet related. So eating a heart healthy diet is huge. Sedentary lifestyle, again, exercising, if you smoke, quit, and that can change so many of these risk factors that we have control over. Which leads me to prevention. If you smoke, yesterday was the time to quit. It is never the wrong time to quit smoking. The first step is to quit. So I hear patients say, well, I've smoked for 50 years, so that I'm done, I'm just going to have a stroke. No, not really. I mean, you drastically reduce your risk for a stroke by just taking that first step and quitting. Diet and exercise are huge. The recommendation from American Heart Association is to have moderate exercise for 40 minutes a day, 3 times a week. You don't have to be a marathon runner or a weightlifter, but going on a nice brisk walk, doing gym exercises on the elliptical, 40 minutes a day. That can be lightweight lifting, that can be swimming, something that keeps your body moving and moving regularly. Preventative medications. So like we talked about on the previous slide of what your risk factors are, if you have hypertension, making sure you've talked to your doctor about medications you may need to be on to help lower your blood pressure. If you are a diabetic, are you on insulin? Do you need insulin? These types of medications that you can take on daily to help reduce your risk of stroke. This is another reason why we highly encourage go talk to your doctor annually. Make sure you're going to an annual physical. You're getting your labs checked regularly so that you know if you're starting to develop any of these risk factors. Even being pre-diabetic can put you at an elevated risk. So you want to make sure you're checking your A1C regularly and having those conversations with your doctor. So signs and symptoms of a stroke. Now that we've talked about what could put you at risk for them or how we can prevent them, let's talk a little bit about how to identify them. So we use the acronym BFAST within Samaritan. Most people are very familiar with the FAST acronym. The B and the E are things that can be a little bit harder to identify, and they can come along with things that we call stroke mimics, but they are still signs of a stroke. So here's a little bit of a closer look at each of those images. Balance is our B in BFAST, and that is for sudden changes in coordination or gait. If somebody is walking down the street and all of a sudden they are leaning to the left or to the right, that's a pretty big indication that something may be going on in the brain. Also, if they're sitting up in bed or on a chair and they are leaning and they don't have good trunk control, if this is happening suddenly, good indication that it could potentially be a stroke. Coordination is another one, sudden loss of coordination. This can also be sudden dizziness. Dizziness that came on out of nowhere falls into this B category. E is for eyes. So this is, again, a sudden change. Anything with stroke is not symptoms that have been developing over the course of time, but that happened suddenly. So sudden vision changes, and this could be in one or both eyes. So sudden blindness, sudden blurred vision, loss of a quadrant of vision so that maybe they can't see just like the left side. Those are all concerning things. This is where patients end up going to their eye doctor because they suddenly are having vision issues, but it's not your eyes that are the problem, it's something going on in the brain. The F is where we get into that fast portion that most people are much more familiar with. So that's the F for face, which is, of course, a facial droop. This is a droop on one side or the other. This can be confused with Bell's palsy a lot. It's that sudden facial droop. It can also be present when you just have somebody smile and one side doesn't go up, a loss of sensation on the face. So that is all facial focused. With it goes the A for arms. This is, again, weakness or tingling numbness on one side of the body. With a stroke, I will say 9.9 times out of 10, it is one side of the body. So somebody may lift up their arms and one droop. They can't hold both of them up. With arms comes legs. Not always. It's not 100% guaranteed that if there's arm weakness, there will be leg weakness, and vice versa. You could only be affected in the leg, but we're really looking for that weakness, numbness, loss of sensation on one side of the body. And then that S is for speech. Speech can be a little bit tricky. It can be a sudden loss of speech, so no words, incoherent speech, slurred speech, or inappropriate responses. So if you are asking someone their name and they are responding, banana or whatever, they're not understanding the words that you are saying to them. And so the words that are coming out aren't making sense because they're not processing that. So it can be pretty tricky. This is also one of those ones that us as nurses and stroke coordinators, we really love having a family member nearby. If somebody is having stroke symptoms, to know what their normal speech is like. Sometimes we think somebody sounds slurred, but that they may always sound like that. So is their speech different than what is normal? And then T, this is the big one. It is time. Time to call 911 and what time did the symptoms start. This is our biggest barrier to stroke care. Like we talked about with TIAs, people like to wait it out and find out maybe the symptoms will go away. But it is always better to be safe than sorry. So the minute those symptoms are recognized, it is time to call 911 and know what time those symptoms started. We have to use this information to make our decisions on how we treat the stroke. So our emergency response, we want people to call 911 as soon as possible. When you call 911 in the case of a stroke, it is setting off a chain of response. So that ambulance crew is arriving. When they are transporting a patient to the hospital, they're calling ahead and saying, we think this patient is having a stroke. And so the hospital starts setting things into motion, and they call a code stroke overhead in the hospital so that everyone knows this patient is coming in. We like to say that especially during that first hour from the patient arriving, that stroke patient is the most important patient in the hospital. We are battling the clock. So we do say, note the times the symptoms began because, as I mentioned earlier, we have a medication you can give for a stroke patient. It is a clot-busting medication. It is called tenecteplase. However, we only have 4.5 hours at maximum from the onset of symptoms to give this medication. It's wonderful. It can help reduce the risk of long-term disability. It can help dissolve that clot and give somebody the best chance at a good outcome. However, the longer we are away from when the stroke occurred, we have a higher risk of there being a bad reaction to the medication. So we really have just a short amount of time that we can intervene. if somebody is having a very large stroke, so we call it a large vessel occlusion, that's a blockage in one of the bigger vessels in the brain, we have 24 hours from the onset of symptoms to potentially send this patient somewhere for them to get that clot physically removed from their brain. That is something that Albany, Corvallis, and our coast sites in Lebanon, we don't have the capabilities to do those in our hospitals. So that does involve a helicopter transport to Providence in Portland, most likely. But we want to find that out as soon as possible. We want that patient to be able to get transported there as soon as possible. Faster treatment improves outcomes and saves lives. For every minute a stroke is untreated, about 2 million brain cells are dying. When tissue and cells in the brain die, that damage is permanent. Our skin cells, we scratch them off constantly and they just regenerate and they come right back. The brain is more fragile than that. It doesn't operate like that. So what is gone in the brain is gone permanently. So this is why this is such a big emergency. I mean, one of my coworkers has said it before that every minute somebody is sitting there letting their symptoms go, it's like, oh, well, that's 12th grade knowledge is gone. Oh, 11th grade is gone now too, all the way down that you're just losing that brain space and it doesn't come back. So we do stress call 911. I have patients tell me all the time, oh my goodness, an ambulance ride is so expensive. And, not to sound morbid, but so is a funeral. Like your life is worth so much more that just go to the hospital and make sure you're getting care if you are in that window, if we can give any care, and then we can go from there. Let me go back. A few things people will ask out in the community is, what do I do? What do I do if somebody is having a stroke? And should I give them something? Should I do anything? Is there first aid I can do? And the answer is really no. You have to call 911. There was this information out years and years ago that, hey, give them aspirin, aspirin is a blood thinner, let's give them aspirin. We highly discourage that because depending on where a stroke is occurring in the brain, it'll change the symptoms somebody is having. One of those symptoms that can occur in stroke patients is that they have an inability to swallow safely. So we don't want them to take anything by mouth, food, water, medicine, just because they could choke, which is just adding another thing to the problem list. So we absolutely do not want anyone to take anything by mouth. There's also really nothing you can do out first aid wise in the community, because in order for us to decide how we're going to treat this stroke, the first step is always imaging. So that patient comes in and the first thing they need is a CAT scan. We need to see a picture of their brain and find out what type of stroke is it. Is it a bleeding stroke? Because then we definitely don't want to give them a clot busting medication and make them bleed more. Is it a large vessel stroke that we can maybe remove? And we go from there. So really we're stopped in the track of treatment until we have imaging done. So it is a call 911. Just call 911 and get to the hospital as soon as possible so that we can determine from there what type of treatment needs to be done. These are a few helpful resources if you ever want to learn more or have questions about strokes outside of just reaching out to your local friendly stroke coordinators. Samaritan Stroke Services, we do have a website, the American Stroke Association and the American Heart Association, National Stroke Association, and if you are struggling to quit smoking, we do have an Organ Quit line. There is also a Spanish option. Ones that I didn't list on here but are also hugely helpful are the Oregon Stroke Network and also the Aphasia Network. For somebody who has had a stroke and is still having difficulty speaking or with language, this is a helpful resource. And they have a camp. There's all sorts of cool stuff. So I highly encourage looking up some of those things. And now I would really like to open it up to questions, because this is where we get to hear from all of you guys. So please drop questions in the chat. And I will help to answer them to the best of my abilities. Okay, can a slow bleed not be recognized as a stroke? So First of all, let's talk a little bit about brain bleeds before I dive into answering that. There are multiple types of bleeds. A spontaneous bleed, so anything that's an aneurysm rupture, or any sort of spontaneous bleed that was not caused by like a blunt force to the head or a fall, goes in the stroke bucket. If it was a fall and a bleed, not technically a stroke, but still blood in the brain. The rate of bleeding really wouldn't change if it's recognized or not. So I'm not a radiologist, but on our CT scans, which is what we do for a stroke patient first to see if there's blood in the brain, it shows up pretty darn clearly. Almost always. It is a white color where everything should be a dark gray. So if there's blood there, it should be detected on a scan, whether or not you're bleeding quickly or slowly. It should still be present. While we're waiting for more people to give a question about strokes, another thing, there's also strokes that you could be having and not know about them. We get patients that once we do an MRI, oh my goodness, they have this evidence that they've had strokes. That is possible as well. You could have a stroke and not know about it because it was such a small vessel. If it happened years and years ago, of course, there's nothing we can do about it, but then we can start looking at risk factors. Great question. Is someone with a history of migraines more susceptible to strokes? Yes, it does put you at a elevated risk for stroke. I can't tell you the exact rate if you're at a higher risk by this percentage, but it is one of those risk factors for a stroke. Along with that, people ask all the time, how do I know if it's a migraine or a stroke? Because so many of these symptoms can be symptoms of a complex migraine. And the answer is ultimately you don't. And so it's better to be safe than sorry. So get to the hospital and find out. However, I understand that if you get migraines regularly, that's a little unreasonable to say up and go to the emergency room every single time. So to caveat that a little bit, if you do get migraines regularly, you know your body and you know what is a normal migraine for you. If there is anything that is abnormal that you don't get with a migraine, or you've taken your migraine meds and something isn't changing, then definitely go get help. You want to find out. Another somewhat helpful hint, I guess, maybe ischemic stroke, so that more common type of stroke, is not painful. Often it is not accompanied by any sort of headache. With a hemorrhagic stroke, that's where it's a little bit different, and it has that textbook symptom of this is the worst headache of my entire life. So it can blur the lines a little bit, but if you are having your true migraine, you are having that headache, and you're having your normal symptoms with it, whether that's nausea, vomiting, numbness, especially if it's bilateral, if you know that's a normal symptom for your migraines, it's not as concerning that it's a stroke. But if it is a new symptom, if that's something you have not experienced before, it is best to just go find out. That was a good question. A few of our other things that mimic strokes very well is low blood sugar. When somebody comes in with stroke-like symptoms, one of the first things we do is we check a blood sugar. If it's low, then we correct it. And if we're still having stroke-like symptoms, then we're going to go find out if it's a stroke. So if you are diabetic, especially, definitely check your sugar if you have a new symptom. If you are low, if your blood sugar is under 50, then absolutely symptoms could be related to that. So that's another one. Just keep a close eye on your blood sugars if you are a diabetic. Sarah and Beth, do you have any frequently asked questions that I haven't addressed?
Something for my own curiosity, if you guys have access to the chat, I would love to hear what you guys have maybe learned today. Something new that was helpful and informative, just a quick word or two of what was helpful. I'd be interested.
Yes, absolutely. Ooh, age-specific things. So we get asked, can you have a stroke when you're young? Yes, you absolutely can. We see stroke patients across the entire age spectrum from, you know, children to, 99, 100 years old. I will say it's less common to see a child have a stroke, but we are seeing more and more young people having strokes. So that's 20s, 30s, 40s. A couple of reasons for that. One, the world of stroke has gotten fantastic at narrowing in on our key demographic of those 65 plus for what are your risk factors and making sure those are taken care of. And hasn't focused as much on the younger people, but also things that are a little bit newer. Like we said, the rise of using oral contraceptives, vaping, especially those two combined, energy drink use, that excessive caffeine, smoking, and then drug use is a huge one, especially in our population here. We see that drug epidemic just puts you at an elevated risk for stroke. So we are seeing younger and younger people experiencing strokes. How important is family history without other risk factors? That's a really good question. It's something just to have as noteworthy. If you do not have any other risk factors, it's just something to keep a close eye on. So if you have a family history, say your dad had a stroke and your dad also, had maybe hypertension and diabetes and a few other things, those are other things we look at as family history. When you talk to your doctor, they want to know a lot of those things because some of them can be genetic. So if you are free of any other risk factor besides family history, it's more of a good thing to know of with what other risk factors could come up from that family history as well. And it's just a good thing to kind of keep in your back pocket as, hey, this might be in my genes to develop some of the other risk factors for stroke. So it's good to be aware of. It doesn't mean you're going to have a stroke, but it's a good information to have. If you have had a stroke, are you likely to have another one? Absolutely. That was a good question, Leslie. You are. Unfortunately, it just puts you at an elevated risk. And really, part of that is what caused the first stroke. So we can help mitigate those risk factors that we may have discovered after that first stroke. But hey, you've had one, you still have those risk factors, and now the added one of your brain has been damaged by this stroke. It could happen again. So really closely following up after that initial stroke, keeping a close eye on all of your labs, making sure you're meeting with your doctor to do everything you can to prevent it. Another big one is if you had a stroke and you're in the hospital, you get put on new medications. Making sure you stay on those or you don't stop taking them until a physician has instructed you to do so. We've had patients that are like, well, yeah, I took my blood thinner, but I took it for like 30 days and then I decided to stop, or my blood pressure medication. So making sure if you've been put on a medication for stroke prevention, before you stop any medication, speak to your doctor first. That was a very good question.
Jojo, do you mind me hopping in real quick?
Yeah, of course.
Somebody had mentioned, I think it's Megan, where she learned that the addition of balance and eyes is a possible symptom. This has definitely been a push in the past like 2 years that these are considered what we considered atypical, so not normal stroke symptoms. And that's because we were finding a lot of what we're referring to as posterior, so strokes that are happening in the back portion of our brain, and they're harder to recognize. So it's very interesting, when we do education, that I would say like 3 years ago, we were very tuned into the specific stroke symptoms that would kind of give us the path of how we're going to treat the patient. And so now it's the point where we're looking at balance, dizziness, eyes, vision, and beyond. And so a lot of times the questions that we are asking the patient when it comes to what interventions are accessible is, how does this affect your quality of life? So it's not necessarily like, oh, their score is really low, they're only having visual problems, we're not going to treat them. That's how the conversations used to go. And now that has completely shifted to where if you have a low score, we will still treat you, because a visual change for somebody who's 75, 80 that's still driving, that's going to completely alter that person's quality of life. We have certain patients that say that their left hand's been altered. That wouldn't change their quality of life, so we haven't treated. But if they said, yes, it's my right hand, that's going to completely change my everyday activities because I'm right-handed. I want the treatment. So it's a lot of patient conversation driven with the treatment, and it's really opened up conversations since they've really they really introduced the B and E portion of our BFAST stroke symptom recognition.
Thank you, Sarah. I see 2 questions in here that I haven't addressed yet. So David did ask, can COVID-19 increase the risk of a stroke? It's a really good question. It's a little soon for us to see exact numbers on how much this will change this world of stroke. I can say anecdotally, so this is not an official answer, when I was working, before I had this job, I worked in a COVID ICU, and I did see a fair amount of patients that would develop blood clots after being in our COVID ICU for a long time. For whatever reason, they would end up with a pulmonary embolism or have a heart attack, or some did have a stroke. So the correlation seems to be there, but it's a little soon for a lot of studies to be done on this. So we don't really have an official answer. But that's kind of something emerging. That's a question that's been asked quite a bit, and we don't have an official answer on that yet. I see down here, what is the most common symptom of a TIA? A TIA can have those exact same stroke symptoms. So speech changes, facial droop, one-sided weakness, the same symptoms of a stroke, they just disappear. I would say, I mean, I think I see the whole spectrum of all the stroke symptoms that end up just being a TIA. So it could be really any of them. But that was a good question. It's looking out for those BFAST symptoms, your main ones, those balance changes, dizziness, vision changes, facial droop, weakness, and speech changes. A good question.
Okay, I have one more favor to the group to ask. Would you please tell me in the chat, did you know what BFAST meant before the presentation?
Right. We like to kind of gauge how well we're able to educate our community around us. So this is super helpful. Thank you for giving us some feedback.
And I think David wrote he knew FAST, but not the BE portion. And you might see that. American Heart Association, they're specific to FAST stroke symptoms. But as Samaritan in the system, we have worked with Providence a lot with education, but also with a lot of medication companies, and a lot of the newer information that was coming at us was definitely trying to focus on those the BE portion of that of those stroke symptoms.
Another question in here, can excessive alcohol drinking contribute to stroke if one has had one previously? Yes, alcohol use, it does put you at an increased risk for stroke. So it is definitely something to keep in mind, everything in moderation. So excessive drinking can absolutely increase the risk for stroke. And looks like Leslie dropped in that survey. Thank you so much for that. And Leslie, I'll pass it back over to you.
Awesome, thank you. And if we can go to that next slide, I just want to thank everyone for joining us today. Great questions. I hope you learned a lot. We do have another upcoming Healthy Minds, Healthy Bodies seminar, and that's going to come up on Monday, October 16th. And once again, if you want to join us on your lunch hour, we would love to have you. And as Jody said, the survey is in the chat, and your feedback is very valued. It helps us know what you got from this, what you'd like to see in the future. So if you could just take a couple minutes, it's a super brief survey, and that's very important to us. And then also watch for a follow-up email that will include a link to the recording and the survey. And thanks again for joining us, and have a great rest of your day.
Thank you, everybody.